Welcome today to everyone who's joining us from around the world. My name is Amanda Makulec. I'm the Operations Director for the Data Visualization Society. I also am the Data Visualization Lead for Accela, which is a tech consulting firm based in Washington, D.C. And I have a background in public health. I have a master's in public health, and I am so excited to have a great panel of folks who are joining us here today to talk all about this important topic of visualizing health data responsibly. We have had a lot of conversations around COVID-19 and COVID-19 related data visualization, but it's important to remember that this is the kind of data that a lot of us have spent our careers visualizing and analyzing and working with. Whether you're an epidemiologist or a public health professional, or even a graphic reporter finding ways to go ahead and visualize and share data with the wider public. So I'm excited to go ahead and dig into this today in our fireside chat. We'll have a couple quick introductions from our panelists, just so you can get to know them and their work. We have a great range of different experiences represented here. We also will then go ahead and dive into questions, both some questions I've prepared to chat with some of our panelists, but also looking for some questions from you. So if you have questions for us that you'd like to have our panelists talk about, please feel free to add those questions in the Q&A box below. Big thanks to Accela, my employer, who is kindly helping us out with the logistics and providing the Zoom for this webinar series today, which enables us to have a large open webinar space for folks to join into. So thanks a lot to Accela for supporting these fireside chats in the Data Viz Society. So we've got 4 panelists lined up today. We're waiting for Harry to join us right now, but we wanted to make sure that we could go ahead and get started. First, I'd love to get an introduction from Tricia. Tricia is joining us here from Baltimore, Maryland. Hi, Tricia.
Hi, can you hear me?
Yes.
Great. So I am joining from Baltimore today. I'm currently a research associate and faculty member at Johns Hopkins School of Public Health. I am within the Department of International Health, and I focus almost exclusively on global health in low and middle income countries. I'm originally from outside of Chicago, so I'm really excited to join you today.
Do you want to speak a bit about your journey right now, Tricia, as we go ahead and do introductions?
Yeah, great. I put together just one slide on what I focus on. I primarily work in monitoring and evaluation of global health programs, so primarily maternal, newborn, child health, and nutrition programs and policies. So I work with governments in developing countries to help them better use their data and improve their methods for data collection and visualization. In terms of data visualization, I help lead trainings on data visualization for policymakers and programmatic staff in developing countries. And the platform focus is primarily in R or Tableau, Public or Excel. I primarily work with free platforms based on the target audience and user base. And so these pictures are just a couple pictures of trainings and the types of products that I've helped government individuals produce.
Great. Thank you, Tricia. Next up, let's hear from Allison. Allison's joining us from Canada.
Hi, yes, I'm joining us from Kingston, Ontario, which is just an hour and a half or so north of Syracuse for the Americans in the room. And I work at a local public health agency. I am actually at work right now because we are deemed essential services in the middle of a pandemic, but I've been able to take some time to talk on this panel today. So I am a program evaluator and data scientist and really do all sorts of things as the day arises. So my work is predominantly in taking what is our large data sets, our analyzed data, and preparing tools right now to help them to display them to predominantly other health professionals. I have here just a few screenshots of some interactive dashboards that I built. I really got started in R and that, but in the recent years I've moved to Power BI because we can't afford Tableau. and then more recently in this screenshot is a tool that I've been building, and this is unfortunately on hold right now, but to display health equity data to other health and social service partners. And so in order to truly build the tool that we need, I've also incorporated custom D3 and JavaScript into Power BI in order to truly show our data in a way that we are comfortable showing it. And then if we go just, I don't have control of the slides, that's just another screenshot of that. And then, of course, what I've been pulled into now is visualizing some of the data we have access to demonstrate what is going on with coronavirus in Ontario, because my organization runs a syndromic surveillance system for the entire province. So we have access to a lot of real-time information about what's going on, and so that's a lot of my work has been in the past few weeks.
And thank you for taking time away from your day to talk to us today, Allison. It is so helpful to have the voice of someone who's actually using this data to inform government policy, not just to inform the public. So I think that that's great. Katie, if we could go ahead and do your introduction last, would love to hand it over to you to talk and show us a little bit about your work. You're on mute, Katie.
Okay, sorry. Great, thanks. So I'm going to share my screen just real quick, and let's do full screen. Okay, let me know when you can see this. Is this good? You can see my screen? Great.
Yep.
So my background is as a user experience designer. So I'm not a person who's up to my elbows in code. I'm more kind of on the design side. And I'm also an autoimmune patient with 25 plus years of dealing with my own health issues. So I'm going to tell you just a little bit about a startup that I've been working on for the past 2 years called Pictal Health. And it really comes from my own experience and struggle communicating about my complex health history. So Pictal Health is a startup helping people who have complex health issues to tell a visual story. So really, I work with people to create a timeline of their whole health history so that they can communicate their story more effectively to their doctors and feel heard and understood as they're working to get the right diagnosis and treatment. So I picked out one sample just to illustrate this concept. So this is a person I've worked with who has a Lyme diagnosis plus some other health issues. I'll zoom in on a few aspects of this. So I create these timelines after a long conversation.
Katie, I don't want to interrupt you, but I don't know that your slides are actually showing so we can actually see these great patient timelines that you do. I'm still seeing your initial Pictal Health piece. So
okay,
I make sure folks don't miss out on those kind of graphics that you've been working to create.
Okay. All right. Let me try that again.
And welcome, Harry. So happy to have you here.
Great to be here.
I hear that we had Wi-Fi challenges, which is the land we live in right now with everyone working from home, right?
Yeah, it's been really patchy, but I'm glad to be here.
Okay.
So let's go ahead. Katie, why don't you go ahead and finish your introduction, then we'll let Harry go ahead and share who he is and what he does, and then we'll pivot over to our questions.
Got it. Okay, so I'm just going to keep this in this view. So this is the type of timeline I work to create with people. I'm going to zoom in on a few aspects of it. So what you see here is a symptom timeline at the top. And this is a graph based not on quantitative data, but really based on an in-depth conversation I have with people where I really try and understand their whole history. So this is an artistic representation of their memory and how they felt over time. Then below that, you see diagnoses they've had, their life events and how big the life event is how stressful it was for that person. And then below that is treatments they've tried. So altogether, the goal is to create a holistic view of someone's kind of whole health history, where they've been, what they've tried. And then we also start to see some correlations, like how factors like moving to a moldy house or having the death of a child seem to correlate with an increase in their symptoms. So I've had positive reactions from both doctors and patients. Patients have said they feel heard and seen and more confident in telling their story. And while these timelines have been created up until now using Adobe Illustrator, I'm working on creating an app that would be a more scalable way of putting together these timelines for patients. So that's my short intro.
Fantastic. Thank you so much. And last up, we'll give him his slide just because you deserve a slide, Harry. This is Harry. Can you give us a quick intro to you, what you do, and your connection back to health?
Sure. So my name is Harry Stevens. As the card says, I'm a graphics reporter at the Washington Post. So like the job title implies, it's kind of a combination of traditional uh, journalism skills like interviewing and finding sources and reporting and writing, but also creating graphics, which includes designing the graphics and oftentimes like coding or whatever people use to implement the graphics. So I've been doing this for about 6 years now. Started at the Hindustan Times in New Delhi, India. That was my first graphics job. And then I came back to the US to work at Axios, and now I'm at the Post. And before doing graphics, I was just I shouldn't say just, but I was a print reporter. So I worked as a crime reporter for the Salt Lake Tribune, where I'd call up every sheriff's dispatcher in every county across the state and ask them if anything interesting or unusual had happened overnight. And so that was like a pretty cool job. Heard a lot of interesting and unusual stories that way. And I really got into graphics because basically I moved to India to follow my wife there. So when I was in India, I didn't have the advantages that I had from being in my native country. Like being a reporter, it's really important to have like a lot of cultural context as well as the linguistic ability to interview people. And I had neither of those in India. So I was pretty worthless as a reporter, but I did have some coding skills and also like the ability to make graphics. So I managed to get a job kind of doing like online interactive journalism there, and I've kind of been doing graphics ever since.
Very cool. And even if you don't recognize his name, one of the reasons we wanted to pull Harry into this conversation is because he does work with some health-related information and is actually the coder and designer behind the Flatten the Curve graphics that you saw in the Washington Post, which I don't do a good service to by not having them be animated on this screen grab. But if you haven't seen this series that he did around Flatten the Curve and some illustrative modeling of what would happen if different interventions were taken, it's a great explainer on what Flatten the Curve looks like. So with that, I'm going to go ahead and pop out of any kind of screen sharing here. I'd love to just kind of talk through a couple different questions with our panelists and get a bigger sense of some of what you guys are thinking about when you hear about responsible data visualization. So I'm curious, what does responsible visualization mean for each of you in the context of visualizing and communicating health data or other sensitive kinds of data? Maybe Allison, do you want to take a first pass as you've come at this from a lens of science?
I can try that, I guess. And again, my audience is not typically the general public, but other professionals. So for me, for my organization, it really is a balance of making the data we have more accessible. We sit on mass quantities of government data and survey data from our Statistics Canada, but making it accessible in a way that it is going to be interpreted correctly. For example, my region, the region I work for, is very small. Our total population is about 200,000. So when we use survey data, our sample sizes are pretty tiny, and you have to be really careful about making sure when the data goes public, it is there in a way that people aren't going to see relationships and trends that don't actually exist. And so it's always a push-pull of making the data public, but doing it in a way that we can ensure that it's going to be interpreted correctly, and can be very time consuming to do that. So how do we balance the two sides of that?
Well, I noticed on your graphics that you had some error bars and other things embedded in there. So it's always tricky to kind of balance those pieces out. I know, Katie, you're working with a lot smaller data in the sense of looking at patient data. What does responsible visualization mean to you?
Yeah, so one thing that comes right to mind is being really critical about the data that we're talking about when we talk about an individual's health record. So if you were to go into my health record and visualize the data that's in the EHR at the hospital, it would give a very limited picture of who I am, and it wouldn't do a good job of telling my story. So to me, being responsible about visualizing a person's record and story means really approaching it from a more holistic standpoint and getting to things like how they felt over time, what happened before electronic health records, right? When we don't have any digital data going back, further than maybe 10 years. So what's happened over the course of their whole life? How do we capture concepts that contribute to someone's health and well-being, like stress? And how do we, make that part of the big picture? So to me, it's kind of going beyond the existing limited data set that we have when it comes to a person's health.
Harry, do you have any thoughts on that from a reporting angle?
Yeah, absolutely. So I've been covering the only story that anybody's been covering for the last couple months, which is COVID-19. And it's a really weird and challenging story to cover as a data journalist, because we have lots of data and it's all wrong. So like we have, all these case counts coming out of various different countries. But the problem is that there's significant underreporting, both because we think that something like 80% of cases are mild. And by mild, I don't mean like you don't feel anything, like you might still have a high fever and get really sick, but mild in the sense that you wouldn't necessarily go to a doctor or a hospital. And if you don't go to a doctor or a hospital, you don't get tested. And so therefore you don't show up in the case counts. And in addition to that, that's assuming that you can get tested if you do go to a doctor or hospital, which we also know is not true. And that varies from country to country, your ability to get tested. So not only do we not know the real number of cases, but we can't compare the trajectory of case growth from country to country. And so that is a nightmare as a data journalist, because like your instinct is to take the data that you have, which we have a ton of it, and try to make comparisons between countries, as well as try to track the trajectory over time. And it's not that you can't do it, like you still, like for example, you can track deaths. Deaths might be a much more reliable indicator because although we know that some people are probably dying of COVID-19 and not being recorded that way, it's much less likely than missing cases. So like we can try to track deaths over time and compare how the outbreak is advancing in countries that way. But generally speaking, like it's this strange situation where we have a lot of data, but the data is really suspect. And generally speaking, like the way that data visualization makes data look is much more precise than it actually is. So like we're in this absurd situation where like, the world passed 1 million cases recently. And so like, we want to write a story, or somebody wants to write a story about that, like 1 million cases of coronavirus in the world. But the truth is that 1 million cases happened, weeks before the official count actually passed that number. And so you're not reporting something about reality, you're reporting something in the numbers. So generally, like this has been a big challenge. Additionally, you have the challenge of reporting about forecasting. And so the public, I think, interprets the results of forecasting much differently than people who do it professionally do. So in fact, I have this great quote from somebody somebody who does forecasts, and I saw it on Twitter. And I'll just read it because I think it really sums up the difference between how the public perceives forecasting and how like people who do statistical modeling see it. So this person said, people who make model-based forecasts don't usually think it is possible to get the model right in a situation as realistic and complex as an epidemic. So we study many models and try to understand the structural risks of the situation that are common across models. Forecasts are not predictions, but ways to influence policy and behavior. The public and politicians engage with predictions in a very different way, and I think this is a dangerous gap between the way people like me think of complex systems and the way the public thinks of the purpose of forecasts, which is to predict the future. So this is a big challenge. Like a lot of times, like the simplest thing you can do is like if you're showing the results of a forecast to at least show the uncertainty bands, which in this case are always enormous. Like if you look at the one that the IMHE has been doing from Washington State, just like, they have like predictions of the number of new cases every day, or the number of new deaths every day, or cumulative deaths. And there's just these huge uncertainty bands projecting into the future because there's so much about this disease that we don't know. Like even when you're forecasting things that people forecast all the time, like the weather, like we still get it wrong constantly, and we have really good data going in, and people have been forecasting the weather for decades. So this is all completely new, and it's very, very difficult to get right. And so that's just some of the challenges. So my approach for the story that you mentioned in the beginning was just to not do a real disease. Like I knew that I wouldn't have the technical expertise to even begin trying to forecast the trajectory of COVID-19. And even if I did, like, there would just be huge uncertainty. And plus that wasn't really the point, right? Like the point was just to try to help people understand the nature of network effects and exponential growth. Mm-hmm. And so by getting rid of like all of the complexity of reality and the specific attributes of COVID-19, I was able to, I think, communicate this idea of just like, there are network effects which make things grow exponentially, but there are also things we can do to disrupt those.
But it's so interesting that you say that, because I'm sure there are people on this call who, when they saw that flatten the curve graphic, maybe didn't read the text and paid attention to the illustrations and thought it was how COVID-19 would play out somewhere. So I think it's interesting thinking about the complexity of systems and the lens and the framework we bring to things. I'm curious, Tricia, from a public health and global perspective, any other kind of closing thoughts on responsible visualization and this piece about complexity?
Yeah, one comment on the public health forecasting and modeling. Unfortunately, I think it's human nature to be uncomfortable with uncertainty. So forecasts or models are automatically latched on by media as a forecast, when modeling is not a prediction of the future. I think it's a very important decision-making, policy-making guide, but the issue is not on those numbers. And I think, unfortunately, with COVID, one problem that's come up is people have latched on to these different models as the truth. It can be extremely dangerous when choosing that and not having a complete understanding of the assumptions that have gone into the model, which are extremely complex and things that most public health professionals still do not understand themselves. And there are many different competing models. So I think it's important to keep in mind that these models are not forecasts, but rather there are a wide range of possibilities. And in terms of decision making and policy making, we want to choose the most conservative, it's better to err on the most dire situation for decision making to be the most prepared in the future. And then one last comment on responsible data visualization. I think there's one aspect of making sure you are using the right data and you understand the data, but then another aspect is the presentation. The JHU dashboard is accessed by over 1 billion people every day. It has become one of the most used sources of COVID data. It doesn't necessarily reflect the best well-built dashboard. And I'm saying this, I'm from JHU and I'm completely independent from the process. But one thing to keep in mind is when designing these very graphic, bandwidth intense dashboards, not everyone can access them as easily as they should be able to access them. And the same with the WHO dashboards and live reporting. Even in Baltimore, there are many times that I can't get the JHU dashboard to load on my computer. So I think it's really important to keep in mind of the presentation of the data in addition to what goes in, what is the data under the hood.
I think it's interesting you asked that, Tricia, because one of the questions that's come in as we look at our questions from our audience is, what is your general opinion on that JHU dashboard? And specifically, are the color combination of black and red too apocalyptical or difficult to read and follow along with? And I think a paired question there that came from another participant around, what about accessibility for health visualizations more broadly? The contrast issues and other things that we're even seeing in the WHO presentations. And I will say personally, I know the CDC reports aren't beautiful, but they use a lot of patterns and other ways to try to make at least the contrast in their charts and graphs accessible. So I'd be curious, maybe Allison, do you have some thoughts on this kind of accessibility question?
Sure.
Or do you love that Johns Hopkins dashboard? Do you look to that as like gold?
I work at a government organization, so we are legally required to be accessible. So it's a regular issue in my job, one that actually we really, really struggle with and has really limited how fast we've moved forward, because there's this push and pull of well, can we even put a dashboard on the website? Or we have a GIS specialist, and there is yet to be an effective way of truly making a map accessible. How do we deal with that? And we haven't yet found a real solution. We found better solutions. I mean, our first solution is we just also always make the data available that goes behind it. You know, the colors are big, and I mean, I echo the thoughts on using red and black, certainly. You'll notice in my small scale COVID related dashboard, I've made a very intentional choice that there is no red. There's not even there's a slight green, yellow, red scale, but they're not actually those colors because I didn't want to make people interpret again what should maybe not be interpreted, because it's all a sense of scale. And we don't know what the background is and that sort of thing. So yes, accessibility is important and very, very hard is about all I've got. I don't have a solution yet.
Yeah, it is tricky from an accessibility perspective. Any other thoughts that people want to add on accessibility before we go to our next question from the audience? Feeling good? That's the tough nut to crack, accessibility and uncertainty, and we're plagued with both of those right now, which is tricky. Katie, Anthony wants to know, what are some of the techniques that people use to humanize data, moving from an abstract bar, line, or curve to an illustration of the human cost or emotion? So given that you've thought about kind of how people look at and see information, any thoughts?
Yeah, I mean, I think apart from, so what I showed you all were kind of, you know, visuals that look like traditional data visualizations, right? There's like these area graphs, these kind of traditional representations, but I guess one thing I've done is, like I mentioned before, try to visualize elements of the human experience that normally aren't visualized. So stress levels over time, symptoms over time, things like that. Another thing I've done is actually created symptom maps on a body shape. I don't have a visual right in front of me, otherwise I would share it, but to help people communicate about their physical symptoms and how their body feels. So especially for people who have invisible symptoms. I'm an autoimmune patient, so a lot of autoimmune patients have invisible symptoms, or people with Lyme disease and things like that. So to help create shapes, use shapes and colors, show them kind of distributed across a body shape to help that person communicate how they're feeling and make their symptoms more real. And I've found that that helps them kind of communicate what's going on with them. And it also helps them to be taken more seriously by doctors who, and even family members who may kind of dismiss them or think that it's all in their head. So those are some tools I've used.
What an interesting concept on the certainty piece, right? Once you plot the symptom like it's another symptom that you can count or quantify, it suddenly becomes more real for other people. I'm curious, as we look at bigger data sets, so not looking at one patient, how do the rest of you look at how we kind of humanize these stories, and especially looking at something that's really as sensitive as this kind of global pandemic that's having so many ripple effects? Anyone?
I can try to answer that. So I think that oftentimes there's a disconnect between the visual representation of a large data set and the human beings who are represented by that visual representation. And so, like, the perfect example, I think, is the flattening the curve chart. Well, not a perfect example, but whatever, it's an example. So this is a graphic that's been making the rounds, and it's definitely really effective, but like where you see this like exponential growth going like whoop, way up if there's no government interventions in slowing down COVID, and then you know, a much lower curve that represents, you know, various policies like social distancing and things like that, and it's like a very powerful representation, and it's been shared a lot. And of course, like the whole point of that is to keep that the peak of that curve lower than ICU capacity or hospital bed capacity, so that not necessarily that you would want to keep the total number of cases lower, but but just that you'd want to make it so that the peak is lower than the hospital capacity. Anyway, that's just a long way of saying that while that's an effective graphic, I think that you can easily forget the people who are behind that visual representation. And I think that one of the reasons, just because I'm on here to talk about the simulator, one of the reasons that the simulator, I think, was effective was that in addition to showing like the curve in that area chart form, it also showed the individuals who were behind that curve. And I was told by people who looked at the graphic that like they would personally relate to one of the circles that was bouncing around. Like they would see themselves in the story of a circle. It would start out healthy and then it would get sick and they'd start to worry about it and wait until it recovered from that sickness. So there was a certain way that showing the individuals behind it drew people in and gave them an emotional response. And I think a lot of the best graphics that I've seen also do this. So like there is a piece in Reuters, I don't know, 3-4 years ago about Rohingya refugees and the scale of the crisis of Rohingya refugees. For those who don't know, this is a Muslim minority community from Myanmar who's been forced out, and many of them are now in Bangladesh. And so there's hundreds of thousands of these people who are refugees. And the Reuters piece was so effective because it showed the refugees as individual people, and it showed them, here's just like a few of them, and then here's more, and here's more, and here's more, to help you try to understand not just the scale, but also the individual stories behind it. A simple thing that you can do sometimes is show individual data points as like little, I think they're called isotopes, like little icons of people, or just like in one individual dot. Sometimes it's hard to do this, like because a lot of times the virtue of data visualization is that we aggregate data and we come up with summary statistics about it. But if you do want people to relate to the individual stories behind it, a lot of times just like representing each person as its own mark can be an effective technique.
It's interesting. Paul actually asked the question about the debate between using circles versus icons, and you brought up Reuters, Harry. Tricia, it makes me think of that article that you just published yesterday with the Reuters graphics team, who's been doing a lot of really great coverage in the current environment. Any thoughts about kind of that representation of people piece?
Yeah, thank you for the kind plug. Yesterday
it's excellent. It's excellent. I think the Reuters graphics team is doing an exceptional job right now and doing wonderful, wonderful work. So highly endorse.
I'm so glad Harry brought it up too, because historically they've done a wonderful job humanizing, I think, data in a more personable way. So with COVID, one piece that comes to mind is their Italy graphic, where yes, we get these graphs of case fatality and these very dire numbers of mortality, but they did a specific piece showing the obituaries in northern Italy and visualizing the volume just in orange of the increased volume of obituaries in the area. And to me, their graphics approach is very unique in, I think, getting to the point of how COVID has affected people. And I think it's a lovely dimension that you don't necessarily see from other types of COVID approaches.
I think that's a great point. I think pivoting a little bit away from the human piece and more around the trustworthiness of data, we have a few different questions about the trustworthiness of data. How do we manage in an environment where, for example, data is really uncertain or being underreported in different countries? Should we be visualizing data that has so much uncertainty in it? Is it ethical to do that? And perhaps the last kind of tied in piece is it an accurate representation to look at all these cumulative graphs where we're looking at kind of this additive effect of cases over time? And Allison, I wonder if you might take that from a public health perspective.
Sure. I mean, I mentioned I deal with uncertainty in our data, regardless of whether or not it's COVID related. And so we have a policy that we rarely put out data that doesn't have, as you saw in the screenshots, those error bars. And I know that error bars are not an effective way of communicating to the general public uncertainty by any means. They're not even necessarily a great way of communicating uncertainty to other professionals, but it's our minimum requirement at least. And we supplement that by wherever we try and we do more communication about the results, we interpret it ourselves and we say, this is where you can and where you cannot interpret it. Data quality is something that I'm quite passionate about. There is, I mean, be it COVID related, be it anything, it's really complicated and only going to get more complicated. The data sets that we are beginning to use in government data are getting a lot more complicated because, for example, be it survey data, people don't answer surveys anymore, and so government agencies are looking into other sources, but the other sources we don't understand as well. They don't have, are we using people's self-reported health from their phones? Well, who is reporting their health on their phones? What biases are in that? There's a lot of uncertainty that you can't even explain from a numerical perspective about who is captured and who is not, and that goes back into the COVID piece. And I always question whether or not we should report data first. I think that's the first step is do I have enough faith in what it is saying for it to serve its purpose, or is someone going to look at this and make a conclusion that they shouldn't be making based on it because of this underlying uncertainty and bias? And again, it's one of those things I don't have a solution for, but I think it's always the first question you have to ask.
Well, and one of the related questions that came up is around this difficulty of assessing that confidence, right? So we have these numbers, but at least to the understanding of Christopher, who asked this question, we don't really have systematic random samples of the population right now, right? We certainly have bias in who's being counted in the COVID data, at least. And as the criteria for testing informs this, resulting in some skewed distributions, how does this impact our confidence in any of these estimates and what we're focusing on right now?
I mean, from my perspective, that's why we try and use more than just that data. I know there's some great, and ethically I question some of it, but some interesting points about people self-reporting, but again, there's bias in that. But it's the best data is probably the data that tries to use as many different sources as possible. So we have the official counts. We use data that is real-time admissions to the hospital, which being in Canada is a slightly better data source because public health care than it might be in countries where public health care is not true. And, we supplement with self-report. We supplement with as many different pieces as we can to provide a better picture than just any one source could provide at a given point in time.
Mm-hmm. I mean, a big part of kind of how we share and visualize that data is around building public trust and having the public trust us as people sharing information. We had a great question from Tony, though, for Katie on your really unique approach that you're actually working to win over the individual trust of each individual patient you work with. So how do you work with them to help them trust you and gain confidence in you so that they feel secure sharing such confidential personal information?
Yeah, sure. So I think there's a few things. Tony mentioned, like, as a non-medic, which I assume means a medical professional. I get that question a lot. How can you do this work when you don't have any training as a medical professional? So one kind of aspect of my work is I'm just trying to capture someone's experience and story and help them communicate it. So I actually find it, I think it's a strength that I don't have medical training, because I don't have that instinct to try and jump to an answer. I'm not trying to diagnose them. I'm not interrupting them. So I think patients are interrupted on average every 11 seconds in a doctor appointment. So I'm not interrupting. I'm only asking clarifying questions and really trying to capture their whole story. So I think that approach of being a listener automatically kind of sets a tone of trust. I do have like a client agreement, like a legal agreement that I have people sign that outlines my responsibilities around confidentiality and how I treat their data, that I won't share their information with anyone. So I think that also sets the stage for trust. But I think more than that, it's just the approach of interviewing someone, being truly curious, and just trying to help them communicate their story more effectively. So far, I haven't had too many issues with people not trusting. So that's
good.
Yeah.
I think a big conversation, pivoting to a new question that's come up recently in the US, has been looking at the disaggregated data, what data we do have, and seeing different groups who are disproportionately affected, like Black Americans. Jessica asked, I'd be interested in hearing the panelists' views on responsible visualization in regard to differences in race and ethnicity. And I think that this is something we deal with a lot when disaggregating data demographically, but is even more sensitive right now. Any thoughts on how we approach that from a place of empathy, understanding, and accuracy? You got to unmute, Harry.
Okay. Well, this isn't something that I've personally worked on. The Washington Post has published, I think, at least one story about the differences in races. So we know that African Americans are, or at least seem to be, disproportionately at risk for dying from coronavirus. And yeah, I mean, so it's definitely a story that should be looked at. I was reading something about like the way that doctors classify cause of death. So it's like there's the cause, which is like what they write down in the hospital, but like, you know, might not really be. So then there's the actual cause, which is like the, you know, I don't know, long-term personal health choices and lifestyle and things like that. And then there's the actual cause, which is like large structural problems that cause certain groups to have worse health outcomes or get sick more, get diabetes more, and things like that. And so what we're seeing right now is like the actual cause, making it so that some groups of people, poor people, people of color, are dying more from coronavirus. And I mean, this is not just coronavirus, of course, this is all sorts of health risks. And yeah, I mean, as far as like how to represent it graphically, like I'm not sure. I think that depends on the specific data set that you see. Like I've seen a lot of slope charts on this one where you see like, you know, on the left side is number of this group of people in the total population. And then on the right side is the number of people who have died from this population group. So, you know, for maybe for the African-American group, the slope would go way up, and for the white group, it would go down. And I think that could be a potentially, you know, effective way of representing the data, but it's definitely an aspect of this story that people should be covering.
Well, and to me, it speaks to the complexity piece. And Tricia, I was going to go to you because this is a whole story of health systems complexity, really, on all the different factors. And I think calling attention to the layers behind that you present those kind of numbers with some context. Thoughts from you, Tricia?
Yeah, one note on the US perspective, I believe last time that I saw, as of last week, only 10 or 12 states within the US were reporting disaggregated COVID data. So it's not just a matter of whether the data exists and if we have the data, but also if policymakers think it's a priority to report. The data that I have seen visualized in terms of race has been done pretty well by, I think the American Public Media conglomerate has tried some dumbbell plots and dot plots to visualize race data, so I can look up that later. From a global health perspective, it's very interesting to see how data visualization will be approached on a country by country basis. Because right now I've been seeing a lot of dashboards creep up very quickly, which is usually how dashboards are created. And I'm curious because it is going to be an aggregate, I think, of multiple data sources. Similarly, I know the DHIS2 folks, which are the routine data system within developing countries, has a COVID module that they've added. So there will be facility level data within countries coming in, but it will be interesting to see if, coming from a global health perspective, it's pretty default to disaggregate data based on sex and race and ethnic minority. And so it'll be interesting to see if that comes out, I think, with the COVID data going forward.
And what a great point to leverage the systems we already have in place, right? And how those systems kind of generate or don't generate data. We actually did an analysis on that question on who's reporting disaggregated data, Tricia. And as of yesterday afternoon, there were 26 states, including the District of Columbia, that were disaggregating by race. and I think 41 by gender. But then Colorado added disaggregated data in the afternoon after we published the quick rapid dashboard. So I'm hopeful that a lot of these nudges will continue to encourage states to make the decision to disclose that information where they can. Maybe let's pivot to something a little bit lighter and a little bit pivoting away from COVID for a moment. There's a question from Jessica on just having finished her master's in graphic design and curious about how you as people working in this space partner with graphic designers in your work, or if you do. Any partnerships with graphic designers?
I mean, I could talk a little bit about that. So my history, my career has been as a user experience designer, and I've partnered with visual and graphic designers to create interfaces, color palettes, design systems throughout my career. And for everything I just shared, I had a graphic designer kind of give me kind of base colors and sort of a design system to work with. And so I'm more of the logic and meaning and content dork and geek, I guess. And then I don't have that like sense of visual style, or I don't have the eye for color. So I always try and partner with people who can bring that. So to me, that's been like a very vital partnership to have throughout my career, because the end product will just look and function even better for it. So.
I think it's an interesting collaboration question, because I think it becomes also a question of how quickly information is shared or not shared and by whom, because part of what we often do in public health is try to also empower people to learn how to create their own visualizations, right? There's a great question here about looking at some of the reports that we're seeing and that we see in public health, that oftentimes they are focused on big picture numbers, right? The national or the country or the state statistics. But it doesn't mean a lot to me, said Steph, and my immediate community. Is there any use or precedent for small data in public health and something more for the benefit of my city, neighborhood, et cetera, instead of just for national policymaking? How do we tell those stories? Allison, unfortunately, by the way, had to step out because she is currently actually experiencing a fire alarm in her building. So she has stepped out for the fire alarm. Any thoughts, though, on this idea of how we visualize small data or small data in public health? It makes me think a little bit of some of the community-based work that I know I've done in the past, where instead of focusing on kind of large national level statistics, you look for what data isn't being collected. Because one of the gaps or challenges can be that you don't have that data, right? If I don't have data to visualize or to share, then it can be hard to create visualization. So I know for a local set of local community organizations, they actually conduct local community scorecards to do community dialogue sessions and use visualization and quantitative data or numbers as a tool as part of a broader community dialogue and advocacy action planning process. And that can be really empowering, because you're not only visualizing local data, you are also collecting that data and have people who are locally trusted gathering that data, which I think is a really important consideration as we think about what that local data looks like, is trusting that it's being collected well and that people are being good stewards of the data. Which perhaps actually pivots to one of the other questions we have here around some of the data around contact tracing that's being raised. And if there are any thoughts about some of the broader conversations right now about contact tracing around COVID-19 and the challenges around privacy. So any opinions specifically asked about Google and Apple's announcement that they're going to team up to use location data to aid in tracing mapping and what that looks like. Any thoughts on that from a visualization or privacy perspective? I know it's a sticky topic. Katie, do you have any thoughts from a personal privacy perspective, having worked with patients, on how they feel about having that information shared?
It's like, I think one thing everyone's talking about is we're in a time of emergency, and that these tools may be very helpful and effective in helping us contain kind of the spread of the virus. But then what happens, and can we turn it off? Can we turn off these you know, these tools that are being put in place. So
is it opt-in or is it opt-out, right?
And what happens after?
Yeah, really fair point. Related to, go ahead, yeah, Tricia?
One thing to comment is, in global health, I think there's been this new trend of precision mapping, and there is weight in being able to have a more detailed idea of what's going on at the local community level. But it's similarly with collecting COVID data over mobile phones, it can be a privacy issue as well. So I think it's an interesting balance between trying to get more hyper-local data, but then also being respectful of the individuals that live in that area, because in some regions where population is quite sparse, it can be very sensitive.
That's a really good point. Another question that came up is related to kind of how we look at electronic health records. Katie, you talked about kind of the translation of EHRs into a more robust patient story. But on the flip side, I know, Tricia, you talked about DHIS2, which is this National Health Information System product that lets us aggregate data up. And Kyle asked that about EHRs. They said that Epic and others suffer from notoriously poor design, making it difficult to get a holistic image of patients or populations. And a non-trivial number of patients might even die each year from medical error related to not having these good data or good data points to look at. What ways can data visualization help to create better health tools for providers and improve health for populations?
I think first, before data visualizers can approach that challenge, we need to make sure that the data is open and that accessible. So I think Epic has notoriously kind of tried to hold on to their data and not let other people have access to it. So that's the first step, I think, is just making sure that people who want to visualize data can get access to it, assuming that there are proper privacy protections in place there.
Tricia?
I think from the perspective of routine health data collection systems, I'm not sure if they're necessarily designed with data visualization in mind, even like with global health or with the US system. There was a study done recently in the past year, and they had actually found out about me through Data Visualization Society, which is a great networking platform, where they looked at the quality of dashboards made in DHIS2 in Indonesia, and they were surprised with, not surprised, but maybe underwhelmed with the quality of the dashboards that were being created with DHIS2. So I think there is the potential. So one aspect is having access to the data, but then also I think as a responsibility of a data visualization practitioner, there's a great opportunity to help with creating a nice story using the data that's available. And I think that's a big opportunity for everyone to be able to play.
Which I think is a great point. There's a question, a follow-up question I think is related that I think is great, a great focus on the impact we have, right? Catherine asked, when we design data visualizations about the pandemic and other health data, we are designing a conversation about the disease and the people the data represent. How can we think through the conversations that will emerge from our visualizations, especially when they change our and our audience's relationship to the pandemic and those who are sick with it? Any thoughts on kind of this question about how the visualizations we create shape conversations and thinking about what those conversations are at the very start? Welcome back, Allison.
Thank you. Sorry, there was a fire alarm. Things you deal with. Though I have to say, watching a fire alarm, physical distancing style, was quite interesting.
Oh, yes.
2 meters apart. Sorry for the interruption.
That's okay. So yeah, so we're just talking, Allison, about the conversations that emerge from our visualizations. So especially when, like, as we think about creating a new data visualization, how is that visualization going to shape conversations, or what are people going to take away from it? What's the impact of what we create? And I don't know if you want to catch your breath for a minute, or if you might want to tackle that one.
Ran back up the stairs.
Give an opinion from like a consumer of many data visualizations. I think a topic to keep in mind is panic. like how much could this cause a feeling of panic in someone who is taking in this visualization, because I've had to kind of limit my exposure to graphs right now because some of them make me kind of put me over the edge. So.
Yeah, how graphs make us feel is a big question. Allison?
Sure. I think panic is the excellent word. In some of my COVID-related work, we've had pressure from reporters and the public to sort of put some of just the raw COVID data out there. And we refuse to, because pretty much the only thing that would accomplish is panic. And so we refuse to put any of the data out without some sort of baseline or context to give it sense of what it means in context of what would normally we would see in the world. Because otherwise all you're gonna get is, very steep lines showing all sorts of things. That's hard for someone to understand because the graph will always resize to have it at the top. So we're always gonna look bad. And how do you put context into it to make it less overwhelming? It's sort of our trick.
So I think as we kind of wrap up today, I want to kind of close with this kind of big picture question on the ethics of what we choose to visualize or not, and the direction we get. So at the end of the day, visualization makes information seem more certain, right? It gives a very precise or seemingly precise piece of information and presumes some kind of delivery of a key message. And Susan asked, do you ever find yourself in a position where you're asked to visualize data from an overly biased perspective? And how do we handle that? What do we do, or what is our responsibility as data viz people when someone asks us to tell a story that isn't really what's there? Harry?
I mean, I think that you have to push back on whoever it is that's asking you to do that. I mean, you are the data visualization professional and you are the person who has the expertise. So if you can have a compelling argument that the data that they're trying to visualize is bad data, or that was collected in a bad way, or doesn't in fact show what they think it shows. I mean, that's even more common, is like somebody will have a really basic rudimentary understanding of the data and think that it shows something that it doesn't actually show, or they think they're trying to draw too strong a conclusion from it. I mean, a lot of times the job of a data visualization professional is to just pour some cold water on people's passion. Sadly, I mean, a lot of times people are just they think that it shows what it doesn't show. And then I suppose if you're in a professional situation where you try to do that and then the person still insists that you make them a chart, then that's an ethical situation that you would have to confront. I mean, obviously you don't want to lose your job. So I don't know what to tell you in that situation.
Any thoughts from our other three panelists on closing this big ethical question of what we choose to present and the story we tell?
I would echo what Harry said. I would refuse, or at least refuse to show, and if outright refusal was not an option, refuse to show the data as they intended to, at least. I would push back and say, well, this data, because we have lots of data that I question the validity of, or, can be used, but only in very narrow contexts. And so it's about, well, why don't we think about what this data can show us and what is reasonable to conclude from the data, and work through it, sort of, I guess, a data story of what we are willing to say this data says and present it that way, rather than necessarily the way intended when they first came to me.
Tricia?
So I think it is a very difficult situation, and just from the global health perspective, I've worked with government stakeholders who are very insistent on specific key messages that need to be conveyed, or specific data sources that should be used, even though they probably are not great data sources. And I think it's very important to relay your concerns, but also within the data visualization, as part of it, increase your transparency of what it's representing. So making sure that you use footnotes, that you explain what the data sources are or what your assumptions are, and also why you may want to tread lightly in terms of interpretation.
And what a great call out on the footnotes. I think especially in this world of social media right now, where graphics get shared outside of the big context, having details and sources and date the data was pulled and all that information embedded in the graphic is so important. Katie, any closing thoughts on this big ethical question on what we share?
The thing that comes to mind for me is, as a designer in the past, when people have said, give us a dashboard. And ethically, I'm like, I don't think you need a dashboard. And just really going back to the needs of the end users when you're designing products or visualizations that need to serve a purpose and help people make decisions. Just going back to what people need and then having that be your starting place.
It's a great point. And I think closing on kind of who we're communicating to, how they see that information, and what stories are we telling through our visualizations, especially of health data, where every data point really represents a person and a person's story and a person's life, or even a person's death. And I think thinking about that and opening and closing with those nods to responsible visualization are really important, especially in today's environment. I know that we didn't get to every single question. We had more than 34 different questions submitted. So I really appreciate folks who were patient with us as we worked through them. If you have any follow-ups, please feel free to send those over our way. You will be able to view this recording and share it with your friends and family. I know my mom just loves watching these. If you're interested in sharing it with friends and family and others, you are more than welcome to go ahead and do so. We'll go ahead and make it available on our Data Visualization Society website. So you'll be able to see it presented here. You'll see it on the DVS website at the Fireside Chats link, where we're loading all of the recordings of these Fireside Chats. Our next Fireside Chat is on web mapping, the do's, the don'ts, the best practices, the not so muches, with some great speakers, including Alberto Cairo, Elijah Meeks, Kenneth Field, coming up next week. Also, you can find us and get updates on these talks over on our DataViz Society, Facebook, Twitter, LinkedIn, and Instagram. Huge thanks to our amazing presenters today. Thank you so much for sharing your expertise and knowledge. Thank you to Allison for running back up the stairs for us. But we'll look forward to continuing these conversations, hopefully over on the DVS Slack, and continuing to have conversations about how we approach this tricky challenge of visualizing health data responsibly. So with that, we'll go ahead and sign off for today. Have a wonderful rest of your day. Stay well, stay safe, stay home. And we hope we see you again next week at the Web Mapping Fireside Chat. Big waves. Thanks, guys.